My name is Antoniette Rosario from Winnipeg, Manitoba. I was diagnosed with congestive heart failure. A cardiologist in the Philippines predicted that I have 100% chance of having a heart attack because he was my parents' cardiologist. And both my parents had heart attacks around age 60 years of age. When I started having high blood pressure in my early 30s, he prescribed me with a high blood pressure pill and daily dose ASA to prevent it. For the next 2 years, after removal of ASA from my medication list, I started getting tired easily, shortness of breath when walking, feeling like a consumed candle while walking, and feeling of drowning when laying down in bed. I had to sleep sitting down at times and more frequent heartburn. One day in 2020, my neck felt like it had a rubber band around it. The next day, while I was going to work, I was having trouble breathing. My supervisor called an ambulance and I was rushed to the hospital. It was March 13, the day the province went into COVID lockdown. I had an ECG and angiogram and was told I needed a bypass surgery, which I had a week after. I spent a month in the hospital recovering. I was afraid when it was time to go home because I wouldn't be around the medical experts if something happened. A change in my diet and exercise helped with my recovery journey. I don't like too sweet food, such as sweet icing in cakes, and I reduced rice portions. I participated in a cardiac rehab program, and it has helped in my recovery. It gave me the confidence to move again, like I did before. It also helped that I went back to work to normalize my life. I am more thankful every day I wake up. I try to control myself to avoid being angry. I like to surround myself with people who make me happy. My message to my audience is diet and exercise are two of the most important factors to help in your recovery. I was invited to the Canadian Women with Medical Heart Issues Facebook group. And I joined in and I learned a lot from listening to their lived experiences. It has helped me to be confident and stay calm about myself, that I am not alone. Thank you.
So in support of Wear Red Canada and the Her Heart Matters initiative, here with us today is Dr. Harriette Van Spall. Dr. Van Spall is an associate professor of medicine and a cardiologist and clinical trialist with a clinical focus in heart failure in the Department of Medicine at McMaster University. Today, we have the pleasure of briefly talking to her about heart failure in women. Thanks for being with us today.
It is my pleasure to be here. Thank you so much for inviting me.
Can you provide us with an overview of what heart failure is and how it relates to cardiovascular disease in women?
Heart failure is a syndrome, and it has a huge impact on our healthcare system. It is the most common cause of hospitalization among older adults across high-income countries around the world. And it is a syndrome that is characterized by shortness of breath and congestion of the lungs, and sometimes congestion of the periphery. So people feel short of breath on exertion, sometimes at rest, and tend to feel bloated with swelling in the abdomen or legs. It's characterized by the inability of the heart to perform its metabolic activities and to provide patients with the cardiac output they need, either due to impaired systolic function or due to impaired relaxation and diastolic dysfunction. And we quantify heart failure by assessing ejection fraction, how well the heart pumps. And people have heart failure across the spectrum of ejection fraction. So even those with normal systolic function might suffer from the syndrome of heart failure, and diagnosis becomes important, but also challenging when the usual measures that people are used to on echocardiography are not met. And therefore, we have criteria that clinicians can use to diagnose patients in a timely manner.
What are some of the known causes or cardiovascular risk factors associated with heart failure?
Heart failure affects both men and women, and the epidemiology changes depending on the type of heart failure. Women with heart failure tend to be older and tend to have a risk factor profile that overlaps with men who suffer from heart failure, but also tends to more commonly suffer from obesity, atrial fibrillation, high blood pressure, and because of their age, other comorbidities that accompany that age. One of them is frailty. People who have heart failure with preserved ejection fraction more commonly tend to be women. Those who have heart failure with reduced ejection fraction, particularly younger patients with that profile, tend to be men. And so while the disease affects both men and women, we see different risk factor profiles and variations in underlying causes of heart failure. Among women with heart failure, the most common underlying cause is either hypertensive heart disease or ischemic heart disease. And this is the case across the world. And then depending on countries that people live in, we might see additional risk factors that account for the burden of heart failure. So managing heart failure should manage both the underlying conditions and the risk factor for those conditions. We also need to keep in mind that women have additional unique risk factors for heart failure that include hypertensive disorders of pregnancy, gestational diabetes, polycystic ovarian syndrome and its accompanying metabolic syndrome, and peripartum cardiomyopathy. In addition, there are things like chemotherapy-induced cardiomyopathy that more women than men suffer from just by virtue of some of the chemotherapies used in breast cancer, for example, that tends to have a predilection for women. It's very rare for men to have breast cancer. And so while chemotherapies have the same effect on men and women, there's certain ones that are cardiotoxic that are more commonly used in certain cancers that women may suffer from.
Thank you so much for that wonderful overview. What information can you share with regard to steps that should be taken to face the specific challenges for women and heart failure?
Right, and this brings us to the point of disease prevention. The best strategy to manage a disease that has had a global burden is to prevent it in the first place. So taking care of the risk factors, early treatment of the risk factors, such as ischemic heart disease, high blood pressure, obesity, atrial fibrillation, alcohol misuse, and other risk factors that we discussed are important strategies to preventing the onset of heart failure. There are medications such as SGLT2 inhibitors, for example, that should be instituted among people with diabetes and cardiovascular risk factors or established ischemic heart disease that can prevent the onset of heart failure. The other aspect is to control the risk factors that culminate in those diseases. So, for example, when we talk about ischemic heart disease, the risk factors for those are cigarette smoking, hypertension, dyslipidemia, familial, genetics that are less preventable, but could be treated if you have, for example, anemia that runs in families that should be treated. And then the other risk factor that's not modifiable is age, but focusing on what is modifiable and instituting a healthy lifestyle that can not only improve how people feel when they have heart failure, but also reduce the risk of heart failure and manage those risk factors that we talked about. And increasingly, we are understanding the burden of obesity, which results in a whole array of disorders, including heart failure. So preventing obesity through exercise, a healthy diet, and focusing on high nutrition foods rather than restricting yourself are ways to potentially manage weight. And for some people, considering other interventions that could include pharmacotherapies, and in some cases, bariatric surgery to manage weight, avoiding misuse of alcohol, and through that, preventing some of the downstream sequelae that could include atrial fibrillation, and treating hypertension. We know that hypertension is undertreated, particularly in women. And so treating hypertension and preventing hypertension through healthy lifestyles are parts of strategies that could prevent and also treat heart failure. The initiation of early therapies once people have heart failure is increasingly emphasized. Historically, we used to start a therapy and see how people feel and then layer on the next therapy. And we've moved now to treating heart failure with the 4 pillars of guideline-directed medical therapy. Beta blockers, angiotensin receptor neprilysin inhibitors, or instead of those in people who can't access that class, ACE inhibitors or ARBs, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And the evidence to support these are particularly high in patients with reduced or mildly reduced ejection fraction. And SGLT2 inhibitors have shown to be efficacious at reducing heart failure hospitalization, even in the normal EF range. And certainly based on your underlying phenotype, for example, if you have diabetes or kidney disease, you might merit from some of those other classes that we've discussed, even at the high end of the EF spectrum.
And finally, could you share some words of wisdom or advice to the audience to raise awareness around women's heart health and well-being?
Yeah, and I would say that we need to be mindful as clinicians that women live with heart disease and face the same risks of mortality, hospitalization, and impaired quality of life than men. We need to remove the biased lens through which we provide care. We have evidence that women presenting with chest pain receive investigations later. Those presenting with heart failure might not be diagnosed in a timely manner. Those qualifying for invasive care may not be referred for those care pathways. And even those who should receive care in comprehensive heart function clinics are under-referred. We know that women themselves may not seek the care they need for symptoms, assuming that those symptoms come from other causes. Women who have cardiac arrest, even when they're witnessed, do not receive CPR in a timely manner. So the strategies to improve outcomes come from both our patients, their loved ones, bystanders, and us as clinicians to recognize the symptoms that people present with. They're often the same symptoms for both men and women, and yet people don't get the care they need in a timely way, often due to biases that we carry as clinicians, gender biases, and ethnic biases, racial biases, and all of the other biases we bring to the table, including biases that pertain to people who are socioeconomically deprived. So sort of removing those lens of biases, both through recognition of them, but also trying to, I talk to my trainees about role switching. Think about the person's journey when you are making a judgment about whether they're adherent to treatment, think about affordability, and also think about what you would do if this person was a man. Would you make the same decisions? Always think about pretest probability, but use the right statistics to guide your assessment of what the differential diagnosis might be. So tips would be for women: live well, nourish yourself well, incorporate exercise, recognize how you are feeling. If you have depression, seek care, because depression is another risk factor for cardiovascular endpoints that we don't want to meet. And when you're not receiving the care that you need, when you have clinicians that don't listen, liberate yourself, find other clinicians that might be better partners in your healthcare journey. And for clinicians, try to use algorithms of care. Try to inform your treatments with high quality evidence, and partner with your patients in a meaningful way so that you have shared goals and achieve them together as a team.
Well, thank you, Dr. Van Spall, for the valuable information you shared with us today. We want to remind you to be mindful, curious, and proactive in the management of your heart health and wellness, because to take care of others, you first need to take care of yourself. Stay safe and heart healthy. To learn more about the unique aspects of heart disease in women and what you can do, visit WearRedCanada.ca or speak with your healthcare provider.